We hope the content is at the right pace and making sense. Just so people are aware, the presentations will be also available on the web, so you don't have to necessarily take notes. You will be able to view these again on a website. Again, our goal is to empower patients so they are not limited by osteoarthritis. I was talking to one of the participants, and there may be a perception that all of this is scary. It's really not meant to be. We want people to understand what the natural progression is. Not everybody moves along that progression, and things like activity, things like managing the condition actually prevent leading to a surgery as much as possible. And that's, again, our goal. If we can empower patients to learn all the alternatives to surgery and use those, because once you have surgery, as good as the artificial joint might be, and they're really, really good and have gotten much better, it's not quite the same as having your own joint. And there is a risk of infection. There are some limitations. And there's kind of a clock. So, you know, even 10, 15 years, 20 years out, there's a risk of needing repeat surgery. So the longer you can put off surgery, it's often advantageous. And of course, there's less risk if you can avoid invasive procedures. So our next presenter is Dr. Hecht. He's going to talk about foot and ankle problems.
But I'm going to speak a little bit about osteoarthritis of the foot and ankle. That's my area of interest and specialty. And this is a repeat. You've already seen most of this, and I'm not really going to talk much about the first four bullet points, but gait is an important part of our lives, and we use our lower extremities the way John says the function of the shoulder is to put the hand into position and do what you need to do. The function of your foot and ankle, of your feet and ankles, is to help you get from place to place. And some people might consider it one of our more highly evolved anatomic parts because it allows us to walk in an upright position. Separates us from the great apes. The arthritis can increase stress on adjacent joints and, of course, can cause pain. So how does it happen? Well, in the foot and ankle, far and away, the most common cause of osteoarthritis is post-traumatic, is injuries. We have occasional instances of primary osteoarthritis, but far and away, the most common cause of foot and ankle arthritis is post-traumatic. We'll see direct cartilage and chondrocyte damage. There'll be abnormal stresses if there's any deformity involved. There's articular incongruity. The joint doesn't fit together anymore. The potholes they're not two-sided, they're one-sided, to use Dr. Cantor's analogy. The joint can be malaligned, and it can cause ligamentous instability, and ligamentous instability can also conversely cause arthritic change. Let's get oriented to the ankle a little bit. 70% of ankle motion is what's called sagittal foot plane motion. That's the up and down, okay? That's what the ankle does. There's some inversion and eversion. That is the motion that our body uses to accommodate to the side of a hill or traverse a ski slope or walk on uneven ground. Normal range of motion of the ankle is about 10 to 20 degrees up and 40 to 50 degrees down. A ballerina is going to have more down. And they treasure that down, the fine line that lines up with the tibia. Below the ankle joint, there are many other joints, and that's what's a little different about the foot and ankle, and we'll get to that too. But the major joints in the hindfoot are the subtalar joint, the talonavicular joint, and the calcaneocuboid joints. And they help provide that side-to-side motion, or the motion that accommodates to the side of a hill. We have many hikers in the audience, I'm sure. That's when I ask people what they want to do, what can't they do, what bothers them, what activities bother them when that trouble their foot and ankle. Hiking is almost number one in the Upper Valley. Normal range is 40 degrees of supination, that's putting your foot in, and about 20 degrees of pronation. Those are all composite motions. They're not simple motions of one joint, but the composite motion of all of those three joints in the hindfoot. And then beyond the joints in the hindfoot, we have other joints. The navicular cuneiform joints, that's across here. Then we have the TMT joints, the tarsal metatarsal joints, and then we have the metatarsophalangeal joints, and then the interphalangeal joints. So that's a lot of joints in which you can get arthritis, and that's one of the challenges of treating the foot and ankle. There's a little bit of sagittal plane motion in these joints that I just mentioned, but they do provide some shock absorption, and they help convert the foot from a supple shock absorption mechanism to a rigid lever that helps propel you forward when you're ambulating. You need to have strength to toe off. Loss of motion here is less significant than it would be in a joint like the elbow or the shoulder, which goes through many degrees of range of motion. What's interesting is that all across the fourth and fifth tarsometatarsal joints, mobility is very important. That's on the outside or the lateral side of your foot. It helps accommodate to uneven ground. The first through fifth metatarsophalangeal joints, sagittal plane motion is very important. That's the big toe in particular, and that's a very common site for arthritis of the foot. The first toe metatarsophalangeal joint. And the interphalangeal joints are less important for grasp than they are in the hand, since we're not climbing trees any longer. So what do I hear from a patient when he or she comes in and says, they tell me, well, doctor, it hurts. Here's where it hurts. And it hurts with this activity. I may have stiffness in the morning for varying degrees of time, varying amounts of time. My activity is limited. I can't do what I'd like to do. I can't hike. I can't cross-country ski. I can't run. Usually cycling is not a big problem because we're just dealing with ankle motion alone and not so much with the side-to-side motion in the bike. And there's most often a history of previous trauma, and there may be other risk factors that could be occupational or familiar. People may have congenital deformities that can lead to these kinds of problems. What do we see? You see swelling of the joints, joint tenderness, decrease in range of motion, palpable osteophytes, these bone spurs that the body creates to help increase the surface area to reduce stresses of arthritis are perpetuated by or limited by the increasing size of the joint itself by developing osteophytes. You can see deformity. You can see lots of swelling. And then people will have an antalgic gait. They'll walk with a limp. How do we look at it? With an X-ray. We get weight-bearing views. It's a little different in the foot and ankle. If we're trying to diagnose a problem, I want to see what that joint looks like when it's bearing weight. It's a very, very important study. It's a simple study, but it tells the tale. People come in without weight-bearing films. It really is not as helpful as we'd like the film to be. So we'll repeat those films. You'll see malalignment. You can see joint space narrowing. The subchondral sclerosis, and sclerosis is thickening of the bone most often because there's an osteophyte there. And then you can see cystic change in the bone that sits just behind the cartilage. CAT scans and MRI scans can also be helpful. We'll see the CAT scan is sort of like a super X-ray. It gives you very, very detailed information. There's unfortunately quite a bit more radiation involved with a CAT scan than there is in a regular X-ray, but it's very good at looking at details of joint problems. This you're not going to see in a regular X-ray. You can also see loose bodies, which are usually broken off pieces of osteophytes. MRI scan is very good at looking at cartilage and looking at soft tissue. It can tell us about bone health also. We can see something called avascular necrosis, which is death of parts of the bone because there's bad circulation. What are our goals? Well, we want people to feel better. We want people to function better, and we want to prevent deformity, correct deformity if possible, and help control progression of deformity. And once again, I'm going to talk about the same things, but very briefly, that Stephen and John talked about. Tylenol, nonsteroidals, glucosamine, these nutritional supplements, corticosteroid injection, and hyaluronic acid injections. That's the Synvisc. Just to clarify that, Synvisc is only approved, and hyaluronic acid is only approved by the FDA for use in the knee. Any other use in the body, although the joints are biochemically the same, is an off-label use. And it often takes some convincing of. It doesn't mean you can't do it. A doctor can do what he or she likes, but it may require some convincing of an insurance company to pay for that. And it's considered a device, not a medication. A cane, a brace, physical therapy for range of motion and strengthening. If you do too much, and this is what Dr. Nutting mentioned, you can aggravate your arthritis. And there are other anti-inflammatory modalities such as the iontophoresis, the phonophoresis, the ultrasound, and possibly acupuncture. I'm fortunate there are so many things that we can do to help the foot and ankle without doing surgery. These are not the most beautiful shoes you've ever seen, but they're very functional. It's called a rocker bottom shoe, and you may have seen these shoes. I'm going to use a brand name. There's a company called Skechers, and there are many other companies who make the same kind of shoe. It's a rollback shoe. It's a very stiff sole, and you'll see people look funny walking in them a little bit. But they're very helpful because they help propel your body through what's called the stance phase of gait. Your foot hits the ground, and because of the shape of the bottom of the sole, it helps rock you forward, and reduces ankle motion that's necessary to get your body weight over your foot or ankle if your ankle isn't working correctly. It used to be we have to make a shoe to do that. It's called a solid ankle cushioned heel type shoe, a SAT heel. You can stiffen a shoe through a cobbler. We can use prefabricated orthoses. An orthotic is any device that enhances body function. So orthotics are not just what you put in your shoe that you might go to a podiatrist to get or buy over the counter from Dr. Scholl's. A brace is an orthotic. This is called an air-cast ankle, air-cast tall walker. These are lace-up ankle braces, and these are orthotic insoles. But any one of those things could be appropriately prescribed to help reduce symptoms. And these are custom orthoses. So something like this could be used if you have terrible arthritis of your ankle, and if you want to reduce motion. We can reduce pain by reducing motion. This is actually made from a cast of a patient's leg. They make a cast and cut the cast off and tape the pieces together, fill it with plaster of Paris, which is porous, put a little pipe at the top of it, and they heat up sheet polypropylene, which is a plastic, draw a vacuum on the pipe, so you have you're sucking down around something that's the shape of your leg, and you heat the polypropylene up to a draping temperature, and that sucks the plastic right down to the size and shape of your leg. So it's a custom-made orthotic device. That's your functional orthotic. UCBL, University of California Biomechanics Laboratory, it's a short version of the same thing. For hindfoot problems, the AFO can be solid or hinged, and we get more sophisticated with something called a patellar tendon bearing brace. So what about surgery? Well, we can debride, we can clean out. We've seen some of that already. Something that's different that we haven't talked about yet is arthrodesis or fusion, and this is an extremely successful procedure in the foot and ankle, and in the hand also. We don't usually do it in other joints anymore. We've been able to get away from it, but because of the increased load on the foot and ankle, there's been great difficulty in designing good ankle replacement prostheses, and we'll get to that in a bit. So joint debridement, this is done with an arthroscope. It's smaller than the scope that's used in the knee and the hip. This is hugely magnified. The normal the normal knee arthroscope is 5.5 millimeters in diameter. In the ankle, it's 2.7, almost half the size. So we're working on a much smaller scale with smaller instruments in a smaller space. It's good for mild to moderate arthritis, and this is what John was saying too. It's good to remove a loose body. Something like this between two cartilaginous surfaces is like having sand in the cylinder of your car. It's not very good for you. You develop what's called three-body wear. You shear off pieces of cartilage, and that will wear, and you develop what's called a tracking lesion. So if this sits in the plane of motion and your ankle's going up and down, that pebble is grinding away at the cartilage, which is a soft, shiny material you'll see at the end, just like you see at the end of a chicken bone. If you ever try and scratch that, that just peels right off. It's very fragile material, and that's why arthritis is as big a problem as it is, one of the reasons why. We can shave bone spurs from the front of the ankle. Don't usually do arthroscopy for the big toe, but some folks are trying to do that. It's sort of a long run for a short slide in my mind. We can remove loose bodies. We can remove inflammatory tissue and deal with cartilage flaps. Different types of arthroplasty are out there. Arthroplasty doesn't just mean replacing a joint, it means repairing a joint. So with the first toe, we can take a small piece of bone off. You can put a piece of tendon or foreign material, polypropylene, polyethylene, into the first TMT joint, and the PIP joints can be resected too for hammer toe problems. We can do implant arthroplasty at the ankle, the first metatarsophalangeal joint, and the PIP joints. These two are not great solutions. This one is getting to be a better solution. It's not where the hip and the knee are, but we're finally getting closer. So what would be an indication to fuse an ankle? And why would anyone ever do that? Why would you want to sacrifice motion? Well, you sacrifice motion to relieve pain and to improve function. And I know there's at least one gentleman in the room who's experienced that with me already. So you have to have pain. You have to fail the conservative treatment. The arthritis has to be severe. You might have a deformity that's as severe as that. Or the ankle can be unstable. That's another reason to fuse it. So what are the advantages of fusing an ankle? It's definitive. It works. It's a wonderful procedure. I'm going to jump ahead to an anecdote. People say, well, I'm going to sacrifice so much by having this ankle fusion. Well, the most extraordinary patient I have who's had an ankle fusion is a physician in the southern part of the state. He's probably in his mid-50s by now. He's had bilateral ankle fusions. He came up, did one side, and a year later we did the other. He has primary ankle arthritis. And I got a card from him from Base Camp Everest. So this is not what I suggested, okay? I don't want to hear anymore. Don't tell me what you're doing. So it's a remarkably durable procedure, and people can do a lot. And then there are folks that are playing doubles tennis for years and years. But what's the downside risk? Well, you do lose normal joint motion. If someone tries to walk quickly, you can tell there's something funny going on. Walking at a regular pace, the changes are imperceptible. You don't see that. There may be a mild functional loss. This is hypothetical, but it's probably the thing that concerns me most, and that is increased stresses on adjacent joints. There's a very good study out of Iowa that showed that 10 years after ankle arthrodesis or ankle fusion, we see radiographic changes of arthritis, and at 20 years, those changes become clinical. People feel it. So that's what people can expect. Some people get right beyond that. It doesn't bother them. Some people are affected more early than that. So here's just an example, really dark. I apologize for projecting. This is a 25-year-old gentleman who had open reduction internal fixation. That's what that means. It means we fixed a bad ankle fracture, and we fused this ankle joint just using 3 screws, but where there used to be a space like this over here, so there's no more joint left. And we use what are called lag screws that have a smooth shaft, so we can pull pieces of bone together, and we get this into a position. It's a functional position. We're looking for 90 degrees from the leg to the foot. So he's had a remarkable recovery. And there are lots of different ways to do this. Compression screws using something called a blade plate or something called an external fixator, which is something like the erector set that you might have used as a child. But there are complications, and there are complications with any kind of surgery. You can have a non-union where the bones don't heal, bones that heal in the wrong position. The hardware can be painful, and you can have an infection. But it's important to understand that the complication rate for arthrodesis is much lower than it is for arthroplasty or joint replacement. So what might be the indications? What would be the reasons to do an ankle arthroplasty? You have to have symptoms. You've got to fail conservative treatment. The arthritis, again, has to be moderate to severe. Right now, we're right in the same territory as someone who'd be having an arthrodesis or a fusion. You want an otherwise suitable candidate. There have to be few comorbidities. In other words, is this person healthy? Have we maximized his or her medical state prior to considering surgery? And can they tolerate the procedure and rehabilitation? Understand that arthroplasty is performed much less commonly than arthrodesis is. To add another bullet point here, the ideal patient is skinny and doesn't want to go ski jumping in his sumo wrestling outfit. That would be a disaster for ankle arthroplasty. The advantages of preserving motion, protecting the adjacent joints. The gait's going to be more normal. They get pain relief too. The disadvantages are what happens with any implant arthroplasty. How long is it going to last? We don't have that 1% a year drop-off, the survival rate that they have in the knee and the hip and the shoulder. We're not there yet. There's a new generation. There's always something new on the horizon. That's here now, but it's untested, if you will. You can get wear debris, you can get loosening. It's very difficult to eradicate the infection if you have one, and it's a much more costly procedure than an ankle arthrodesis is. Not to say you can't have it or people can't do it, but it's a bit of a push in healthcare in 2013. This is becoming a more and more important factor. So this is actually the new guy in town, and it's finally orthopedic manufacturers have come to understand some of the technological advances that have occurred in knee replacement and hip replacement. This is something called trabecular metal, which gives good early fixation, and it's probably the best implant, the best ingrowth material that we have. And the polyethylene, which is being used here, is a cross-linked polyethylene. It has better wear characteristics, and this is the first ankle joint replacement that has it. It's been in knee joints and hip joints for probably 5 to 10 years already. So we're catching up. But so far, there are only about 58 of these implanted that just came on the market in October. So it's still a new device. And this is what it would look like implanted. It also is put in a different way. It's put in from the lateral side. You have to cut the fibula, take a piece off, fold it back, and do all the work that you're going to do here with a machining device, and then put these resurfacing pieces in. Very different from every other ankle replacement, which is done from the front where the skin is not as forgiving, if you will. There are lots of complications with wound healing from the earlier generation of ankle replacements. This can happen with any ankle replacement. This is an earlier component or earlier type of prosthesis that is actually still being manufactured and used, but it's unfortunately flawed. This didn't happen because of the prosthetic. It happened because of the patient and because of the implant technique, I'm sure. Skipping from the ankle a little further down to the subtalar joint, we talked about that. When do you fuse a subtalar joint? If there's isolated arthritis, and that can occur with someone who's had a calcaneus fracture and have joint incongruity under that. They have to have no fixed forefoot deformity. You're going to lose some motion, but it's very good at reducing pain. And once again, we use screws that are what we call lag screws. Talonavicular arthrodesis, this is another joint further down in the foot that can be affected by arthritic change. And then we have a triple arthrodesis. All three of those joints can be fused. And here's a bad deformity that's been repaired by putting the bones back in the position that they need to be in and using screws to hold things in place. Another method, I'm going to race a little bit because I'm impinging on someone else's time. But you can fuse every joint in the back at once, the tibiotalo-calcaneal joint. And you can do it with a blade plate, or this is a rod that comes up from the bottom of the foot. These are mostly done with people with severe post-traumatic problems, motor vehicle accidents that have gone on to painful non-unions or malunions. Blade plate for the same thing. The midfoot is an interesting area to me because it's sort of one of the orthopedics unanswered questions. Mostly, midfoot arthritis comes from what's called a post-traumatic arthritis or a Lisfranc injury. Lisfranc was one of Napoleon's battlefield surgeons who described an amputation at that level of the tarsometatarsal joints, and we'll get to where that is in a second. Loss of joint space right across here. That's in the middle of the foot, sort of between the ankle and the forefoot. You see arch loss, midfoot abduction, or the foot turning the wrong way, and gait abnormalities, and an inability to really push off very well because you can't lock those joints with your muscles and also with just the anatomy of the midfoot as you progress through gait, as your foot changes shape. And what can we deal with? How can we deal with it? With a stiff-soled shoe, activity modification, again, bracing. We're harping on the same theme here. This is a 22-year-old girl who's in a bad motor vehicle accident, and she has, you can see here, that this bone doesn't look like it belongs, like it's sitting where it belongs. This accident occurred before I ever met her, and she was treated, it was probably 5 years ago, 5 to 8 years ago now. You can see her fracture. And then she's treated with an external fixator. That's what these pins are, and with some pins to help line up the toes. Big erector set, looks pretty good, questionable function down the line, and at 2 years out, she's got pain under the big toe. She's got pain across the joints, the tarsometatarsal joints, between the ankle and the forefoot, and she can't stand for more than 30 minutes. This is a 20-odd-year-old girl. She can't walk a kilometer. This is what she looked like when I met her. Looks pretty good from the top. The alignment has been rectified. Looks a little funnier as you get the oblique view of the foot. The foot's turned a little bit, and then from the side, this doesn't look right. And that's why she's got pain at the big toe, because she's standing on a post. It shouldn't be shaped that way. And through fusing some of the joints in her midfoot, we fixed the alignment here, which didn't look too bad. But the major improvement is across here, and she enrolled in the Army. It was like unbelievable. Yes, sir. So, you know, fusion is a good thing when it's applied correctly. One of the most common forms of arthritis in the foot, and we're getting to one of my last points, is the first metatarsophalangeal joint. So when you see someone who's got a bunion, a bump on the side of their foot, that's usually not arthritic. If the bump's on the top of the foot, that's arthritic. It's called a dorsal bunion or a hallux rigidus or a stiff big toe. Someone in the audience probably has it. You really can't bring the toe up as far as you'd like to go, and it hurts every time you try and toe off. Or if you're doing yoga, you try and do a downward-facing dog and bring your big toe up and lean your body over your foot, it's not going to work very well. So you're losing motion across here. Normally motion's about 55 degrees. From neutral to 55 degrees of coming up. Someone with Hallux rigidus may not be able to do anything at all. This is how the joint functions. When your foot's on the ground, and then you lift your heel up to walk away, and all that motion, when your forefoot stays on the ground and the rest of your body travels over your forefoot, is at the first metatarsophalangeal joint. Most often it's from a traumatic phenomenon, a hyperextension injury. It can be anatomic because the metatarsal head is flatter than the round head, or the first met may be long. Someone may just be born a funny way or walk a funny way. There's a wide variety in the range of normal. Shoes, again, you can make changes. This is one of the times where orthotic prescription makes some sense. But if all those things fail, you can do a couple of different things. You can cut the bump off, clean out the joint. You can cut the bone and fix the alignment, or you can fuse it. And that's been a very successful operation in the hands of many docs, where you can see on x-ray, you'll see a big bump like this. Take the bump down and maybe get some more motion from the cheilectomy, which means cutting off the bump, basically. You take 30% of the joint surface, and it's an easy operation to recover from. You're walking, putting weight on it early on. It takes several weeks to months to get a final result from that, though. How do you do an arthroplasty, the first MP joint? You can cut away the joint. That's the Keller arthroplasty. You can bring some soft tissue in, which doesn't work all that well. It takes a long time to recover from. You can put an implant in, which will almost guaranteed to fail. This is the Keller arthroplasty, resecting a piece of bone. Not good for an active individual because you lose that push-off strength. Soft tissue interposition is like a Keller. You do a small Keller. You cut part of the base of the phalanx off and put soft tissue into that place, but it is not the greatest thing going. Not heartening results. Implant arthroplasty, there are no good long-term results. That's joint replacement of the big toe. And you can use metal or silicone or hemiarthroplasty. It's been a problematic procedure. Here's a piece of silicone that's splitting at the base of the phalanx. You get wear debris, which is a bigger problem in silicone than it has been for polyethylene. Metallic implants, failure there. Arthrodesis, what's the disadvantage? You do lose motion. Usually when someone's come to arthrodesis, they've already lost the motion, but it's painful. We take all the motion away, and generally most of the pain goes away after that kind of a procedure. Other potential problems, the gold standard for the procedure is still, for bad arthritis, is still arthrodesis. We go from that, we use several cross screws to stabilize the joint until it heals, but it takes about 8 weeks for the fusion to heal. It takes a while. Excellent results, 90% fusion, near normal gait. People are playing doubles tennis, and they're doing well with doubles tennis if they played before. So just to reiterate what we started out with, first, do no harm. Try everything before you do any surgery. The stepwise approach or the ladder approach is most reasonable. You begin with a benign intervention and progress carefully through the use of oral medications. Consider injection. If you can't control symptoms and the patient's a candidate, you can consider surgical intervention. That's pretty much the story with foot and ankle arthritis. Okay.